Welcome to the ECG 5-Minute Consult, brought to you by myself, Sung-Young Hiva Lee, and co-author of ECG for First Responders, Dr. John Hayden. Special thanks to Life in the Fast Lane for the ECG reference materials. Now let's get started on today's case. Today, we have the next installment of 10 Deadly Sins on ECG, abnormal findings that must not be missed. For these, we will highlight 10 potentially lethal ECG patterns that may go unrecognized. Awareness is the first step in preventing cardiac disasters. You arrive on scene responding to an emergency call for a 78-year-old woman in her home. EMS was called by the family of a 78-year-old mother who lives independently. She's experiencing nausea, vomiting, and mild confusion. She's afebrile with a blood pressure of 122/76 and is breathing 16 respirations per minute. She reports feeling dehydrated and is sitting with both hands over her stomach. Her past medical history is significant for rheumatoid arthritis, mild congestive heart failure, and atrial fibrillation. Her listed medications includes ibuprofen, digoxin, and lisinopril. Before we look at our ECG, let's review our ECG primary survey approach. We use the ECG primary survey approach to quickly identify potentially life-threatening emergencies. Using this approach, first responders should be able to address these 4 questions. 1. Is the heart rate too fast or too slow, causing cardiovascular instability? 2. Is the rhythm supraventricular or ventricular in origin? 3. Are the ST segments consistent with an ST elevation myocardial infarction or a non-ST elevation myocardial infarction? And 4. Are the T waves consistent with a STEMI or an NSTEMI? With this in mind, let's take a look at our patient's ECG. First, let's look at the rate. You can estimate most heart rates by applying the 300, 150, 100, 75, 60, 50 sequence. The peak R waves in this case are more than 6 large boxes apart, so we can estimate the rhythm is less than 50 beats per minute. You can estimate very slow rhythms by counting the number of QRS complexes that occur during a 6-second time period, or 30 large boxes, and multiplying by 10, giving us approximately 40 beats per minute in this case. This patient's slow heart rate may be useful in creating a differential diagnosis. Next, the rhythm. The QRS intervals are narrow as defined by a width less than 3 small boxes. Because the QRS intervals are less than 3 small boxes, we can deduce that the rhythm is supraventricular in origin. Next, let's examine the ST segments. ST segment elevation is seen in leads V1 through V5 but lack characteristic convex tombstoning appearance seen with cardiac infarction. The remaining ST segments appear normal, that is that they rest on the baseline or the isoelectric line of the ECG. Remember, ST segment elevation or depression in a minimum of 2 side-by-side leads may indicate our cardiovascular event. The leads overall appear unremarkable for acute ST segment changes. Next, let's examine the T waves. The flutter waves seen on the rhythm strip below represent atrial depolarization. Because ventricular conduction is effectively blocked, there can be no ventricular repolarization, and thus no T waves. Let's test your knowledge. What is the most likely cause for this patient's symptoms and ECG findings? Is it A, STEMI, B, medication, C, cleaning product ingestion, D, dehydration, or E, Alzheimer's disease? The correct answer is B, medication. This case is an example of Digoxin-Induced Dysrhythmia. Digoxin can cause a multitude of dysrhythmias, classically including supraventricular tachycardia due to increased automaticity and slow ventricular response due to decreased AV conduction. Other common dysrhythmias associated with Digoxin toxicity include frequent PVCs, sinus bradycardia, slow atrial fibrillation or flutter, and any type of AV block. So if we take a moment to look at our ECG, we can see on the rhythm strip the atrial flutter with a slow ventricular rate due to the digoxin toxicity. In 1785, Sir William Withering was the first to describe the use of the foxglove plant, Digitalis purpurea, for treatment of heart failure. Digoxin belongs to a class of drugs called cardiac glycosides. These medications increase the force and rate of ventricular contractions. They are prescribed for patients with atrial fibrillation, heart failure, or left ventricular dysfunction. Data from poison control centers in the US indicates that digoxin continues to account for significant morbidity and mortality. Digoxin toxicity common symptoms include nausea, vomiting, anorexia and diarrhea, blurred vision, yellow/green discoloration, visual halos, palpitations, syncope, shortness of breath, confusion, dizziness, delirium, and fatigue. Suspect digoxin toxicity in patients exhibiting these symptoms with a history of heart failure and/or atrial fibrillation. Here are the critical points about digoxin toxicity. Determine the amount of drug taken and time of consumption, as this is important for interpreting digoxin concentration. Determine if toxicity is acute or the result of chronic usage. Ask the patient if digoxin is a regularly taken medication or if the patient may have taken someone else's prescription. Ask about any acute illness, such as gastroenteritis, leading to dehydration and renal impairment. This may cause elevated potassium level affecting cardiac function. Also ask about visual disturbances that are common with chronic digoxin toxicity. Ask about recent dosing changes. Some medications such as verapamil and amiodarone may increase digoxin concentration. That concludes this segment of 10 Deadly Signs on ECG, abnormal findings that must not be missed. As a review, last time we covered a 59-year-old man with mild chest pain who ended up having Welland syndrome, and today the 88-year-old female with weakness, anorexia, and confusion who is experiencing digoxin toxicity. Thanks for tuning in to this edition of the ECG 5-Minute Consult. For more information, check out our book, ECG for First Responders, available on Amazon. Until next time.